Think of a post-DVT leg as a plumbing system, where the main river has been blocked by a dam. When the deep venous system is obstructed by a prior clot, blood is forced to reroute and find a secondary escape route through the Great Saphenous Vein, or GSV. Visually, you are looking at two distinct states. Pathological reflux happens when valves fail, dropping blood backward down the leg. Compensatory collateral flow looks completely different. Blood is surging forward continuously through that secondary channel to bypass the deep blockage. Because both reflux and compensatory flow can exceed the standard 500 millisecond threshold, diagnosis requires more than a single timer. You must map the flow's direction while simultaneously assessing the patency of the deep system. If a clinician mistakenly ablates a compensatory GSV, they cut off the leg's only escape route, triggering catastrophic swelling. To properly differentiate these pathways, the assessment requires an optimal standing baseline patient position. To find the source of the rerouted flow, you perform a top-down evaluation of the deep venous axis. Start by checking B-mode compression for chronic post-thrombotic physical changes, specifically looking for wall thickening, synechia, and irregular recanalization. This graph shows the Doppler waveform at the common femoral vein, which acts as a critical diagnostic window. A loss of respiratory physicity resulting in a continuous, blunted monophasic waveform is an indirect alarm for hidden proximal iliac or IVC obstruction. For deep reflux thresholds in the femoral and popliteal veins, look for durations exceeding 1 second. If deep reflux velocities exceed 10 centimeters per second, it indicates severe deep disease is driving the superficial flow. Next, check the hidden bypasses. The profunda femoris serves as a vital collateral when the femoral vein is blocked, and pathological reflux here is marked by a threshold of 0.5 seconds or greater. Assess the tibial veins as well, as they are critical if the patient has active or healed ulcers. Clearing the deep axis first reveals whether the superficial flow is an isolated problem or a visible reaction to a silent blockage in the pelvis. Only the common femoral vein waveform can reveal this invisible danger. Standard thresholds fall apart if the provocative maneuver fails. Use the Valsalva Maneuver for the common femoral vein and the saphenofemoral junction. For segments below the junction, you must use distal augmentation. In the superficial system, the primary truncal reflux thresholds are greater than 500 milliseconds for both the great and small saphenous veins. Map the accessory veins, especially the Giacometti vein, because it readily transmits reflux between the GSV and SSV networks. This diagram shows perforating veins acting as doors between the deep and superficial systems. A pathological perforator is at least 3.5 millimeters in diameter with a half second of reflux beneath an ulcer. Monitoring its flow direction, inward versus outward, proves whether the superficial flow is acting as a compensatory bypass. Collateral pathways act as emergency fire escapes. Track the deep lumbar, sacral, intermediate, and iliofemoral networks, paying specific attention to the suprapubic cross-growing pathway. Let's test this logic. If you are scanning a post-DVT patient and find continuous antegrade flow in the GSV paired with a monophasic CFE waveform, what is your diagnosis and immediate next step? That specific combination proves the flow is a compensatory bypass. Ultrasound is no longer sufficient. The immediate next step is CT or MR venography to locate the hidden pelvic obstruction. When extensive post-thrombotic deep vein obstruction is confirmed and the GSV is acting as an antegrade bypass, superficial ablation must be strictly avoided or deferred. The Society for Vascular Surgery guidelines are explicit. Collaterals to suprapubic and abdominal wall veins must be preserved during any superficial ablation. Removing them removes the primary outflow for the limb. There is an exception to this rule. If the obstruction is isolated strictly to the iliofemoral segment, combining superficial ablation with iliac vein stenting yields better patient outcomes. Furthermore, when ablation is properly indicated, using radiofrequency ablation carries no increased thrombotic risk for patients with a prior DVT history compared to those without. This 5-step checklist ensures your treatment plan accounts for the full hemodynamic interaction between the deep and superficial systems. Check deep patency. Assess CFV phasicity, determine GSV direction, apply duration thresholds, and map the collaterals.